welcome everyone to the June ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we'll be discussing the article entitled The Impact of Facial Asymmetry on the Surgical Outcome of Crooked Nose, a Case Control Study. A couple of reminders, please mute your microphone, and if you have a question, please ask it in the chat box or raise your hand. And we would all love it if you turn on your video cameras and interact, make comments, the more the merrier. So tonight I'm joined by YAPS committee member, Dr. Denise Sarhadi, who will be fielding your questions and presenting the poll questions, which we'll review at the end. So I'd like to begin by introducing our author and then we'll get into our discussion. And bear with me, this is going to take a few minutes with these three distinguished speakers. So to begin, we have the honor of having author Dr. Babak Saidi. Dr. Saidi is coming to us from Iran, where it's currently 4:30 a.m. So thank you so much for joining us. Dr. Saidi is a full professor at the University of Tehran, and he was actually the youngest faculty member to earn this title. He trained in otolaryngology and has completed a facial plastic surgery fellowship at Stanford. He's published 78 scientific articles, and he's the head of the scientific committee of the Iranian Society of Facial Plastic Surgery and Rhinology. So welcome, Dr. Saidi.
Thank you so much.
Our first discussant is Dr. Jamil Ahmad. Dr. Ahmad practices in Ontario, Canada. He completed plastic surgery residency at UT Southwestern and a fellowship in breast reconstruction at the University of Toronto. He's an assistant professor at the University of Toronto, and he's the course director of the annual University of Toronto Aesthetic Plastic Surgery Symposium. He serves on the board of directors for the Aesthetic Society and is the chair of the Education Commission. He also serves on the board of directors of the Canadian Society for Aesthetic Plastic Surgeons and the Rhinoplasty Society. Dr. Ahmad has authored more than 130 articles and chapters in plastic surgery. He co-authored Dallas Rhinoplasty, as well as Secondary Rhinoplasty by the Global Masters, and most recently, the Dallas Rhinoplasty and Dallas Cosmetic Surgery Dissection Guide. He's on the editorial board of ASJ and is a section editor for ASJ Open Forum. I'm not sure how he has any free time. So Dr. Ahmad, thank you for joining us. And our other discussant is Dr. Derek Steinbacher, who attended Harvard Medical School and trained at Mass General, Johns Hopkins, and Penn. He's a professor of plastic surgery and chief of craniofacial and maxillofacial surgery at Yale. His clinical focus includes rhinoplasty, orthognathic, and facial skeletal aesthetic surgery. His research includes a large clinical series of 3D rhinoplasty and orthognathic outcomes, tissue engineering, artificial intelligence, and other aspects of plastic surgery. So thank you, Dr. Steinbacher, for being here with us. All right, so let's get started. We're going to turn it over to Dr. Saidi, who will share his screen with us and discuss his article.
Hello, can you see my slides?
Yes.
Yes, we can.
Yes. Hello to everybody. It's my honor to be invited to Aesthetic Society Journal Club. And also I'm so happy with our colleagues, Dr. Ahmad, Dr. Albert, Dr. Steinbacher, and Dr. Sarhadi, and the other colleagues. The topic that I want to talk today is about the impact of facial asymmetry on surgical outcome of a crooked nose, a case control study, my recent published article with my colleagues. All of you know about the difficulty of fixing a crooked nose, especially when you have asymmetric face as well. Sometimes when you want to build a building on uneven basement, it's impossible. And so many times we have such kind of uneven basements, especially for mid-face, when you want to fix a crooked nose. Because of that, over the years, me and so many others colleagues told to the residents and fellows that think about the asymmetry when you want to evaluate a crooked nose. When you have asymmetry, definitely you won't have a good outcome comparing to a symmetric face. Because of that, we designed this research project, and the aim of our study was to evaluate the impact of facial asymmetry on patients' postoperative satisfaction with crooked nose. Really, it was my research project when I was at Stanford. I got IRB approval there, but I couldn't finish this research project there with my mentor there, Samos. When I come back home, I tried to do the same research project in my patients. 63 septorhinoplasty patients who had deviated nose included in this study. We divide the patients into two parts, some of them with symmetric face and the other group with asymmetric face. Also, we divided the crooked nose into I type of deformity and C type of deformity. We had some exclusion criteria you can see in my article as well. We review different method of evaluation of asymmetry, and we try to add something to that. So we divide the face into three parts and evaluate each part differently and separately, and ask three observers to give us their opinion about the asymmetry of each part. And also finally ask them to give us the whole face perception of symmetry due to asymmetry of all units. For the first step of our research, we try to evaluate the visual perception of asymmetry from the observer. Also, we use anthropometric measurements. At first, we point some landmark over the face, the glabella, lateral contours, tragus, alar margin, oral commissure, and measured their distance with the midline reference line. And when there was an asymmetry, the difference between two sides of the face, consider them as asymmetry. Also, we measured the angle of deviation of whole face from the line between two copoid bow and from the midline reference line. For the first step of our research, we find a significant relationship with the upper face from the glabella point to the visual assessment of asymmetry, and also for the lower face, oral commissure to the lower part. Also, we measured the angle of deviation by definitely for the I type of deviation and C type of deviation, we need to measure it differently. For the I type of deviation, the angle measured by a line from the tip point to nasion and comparing to the midline reference line. And for the C type of deviation, at first we marked the maximum angle of deviation on concavity and measured angle from the tip point to nasion from this selected maximum concavity. I want to try a review briefly here my method of surgery. As you know, the septoplasty is the major step for fixing of a deviated nose. We did modified extracorporeal septoplasty for severe case. Definitely after modified extracorporeal septoplasty, we need to do some type of reconstruction, usage of extended spreader graft, anterior septal reconstruction. When it was possible, I used upper lateral spreader graft for all cases. Also, the usage of unilateral or bilateral spreader grafts when there was still any deformity. and all tongue groove was performed in all cases. For better evaluation of the preoperative status and post-operative outcome, I used the ESHNAS. I used the Persian version of ESHNAS. I was published the validate Persian version of ESHNAS on Maxillofacial plastic surgery. I used that questionnaire for preoperative outcome and preoperative and outcome after the surgery. When we evaluate our results, all angles, all scores were better than before, but unexpectedly, when I compared two groups, we couldn't find any significant difference between two groups. Really, these results was unusual for me. So I reviewed the literature and I found out that some other researchers found the similar results. For example, the Hossein in 2015 find the similar results, and he interpreted the results that possibly the straightening of the nose as the most noticeable part of the face might cover the residual facial deformity. So my recommendation is that careful patient selection and comprehensive preoperative consultation are mandatory for post-operative satisfaction. Also, I saw a recent article, Busquel and their colleagues published for this same topic. Dr. Ahmad mentioned in their commentary. When I reviewed that article, I found that we have similar object, but our method are a little different. They used also ESHNAS, but I didn't see that they used the Turkish version of the validated Turkish version of ESHNAS in their article, which was published with Dr. Opaydin. Also, the ESHNAS questionnaire has two parts, the cosmetic part and the functional part. You need to interpret the data separately in these two parts. So, and also they use only 2 points over the face for evaluation of asymmetry. Possibly different methods can give us different results. Thank you so much. That was my presentation. If you have any question, I'm ready to answer it.
Well, thank you, Dr. Saidi. That was a really comprehensive and wonderful presentation, so thank you. So Dr. Ahmad wrote a great discussion to this paper. We'll turn it over to him for his comments.
Great. Well, thank you, Mark, and thank you, Denise, for the invitation to participate tonight. I always feel really honored to be around great faculty, and also my good friend Derek to make some comments. Now, the first thing I think that goes without saying is I just want to congratulate Dr. Saidi for putting together a great paper. I'm always astounded with these type of papers because anyone who does a lot of rhinoplasty or facial surgery understands just how hard it is to take care of some of the patients with all the pre-op and the post-op. And then if you add into that complexity of trying to run a study and take really accurate photographs, do all the measurements, make sure everything's standardized, make sure people don't fall through the cracks, to actually get any reasonable number of patients into a study is tremendously taxing and time consuming. So Babak should be congratulated for contributing something novel to the literature. I think, you know, the highlight point here is that in my experience, and I think everyone else here who's taking care of rhinoplasty patients would say that the rule, not the exception, is that patients don't realize they have facial asymmetry, whether that's rhinoplasty, facelifting, and you can even extend that to anything where there's another half, so breast, buttock, even the abdominal wall. And so it behooves us that as we observe these things and we try to educate our patients preoperatively, to walk them through this and educate them and let them know what the starting point is. I trained in Dallas, and most of what I do in rhinoplasty was learned at Dallas Rhinoplasty. One of the things that Rod would always say is, if you tell them before surgery, it's their problem, but if you tell them after surgery, it's your problem. So I think a big part of the counseling is getting all of this on the table in the front end. So you start off on the same page and there's no surprise on the back end, because really we have to ask ourselves, how are patients to know? They're not experts at this. Hopefully they only do it one time in their life. So I think this study really underscores that principle that these asymmetries exist. They do impact outcomes to some degree, and patients should know beforehand. Now, in my commentary, and I won't belabor it very much because you can read it, it's reasonably short. There were a couple of small things methodologically that I just thought I might have done a little bit different. One was looking at the face as a whole as opposed to 3 subunits. Personally, that's the starting point for me when I'm doing clinical analysis, for a case, trying to prepare what I'm going to do. I find it much easier to look at the face as a whole, maybe, put a line down the middle, and that helps to unmask some of those asymmetries, the big stuff. Maybe put some horizontal lines. If you put horizontal lines through the brow, the nasal base, the commissures, you start to see that these aren't parallel, and that's an easier way to see some of these asymmetries. So those are just quick, easy, unsophisticated things to do. And then, and I'm sure Babak had a reason why he decided to divide the face into thirds. Maybe it seemed like it might be a little bit easier to analyze by thirds, looking at facial asymmetry. But for me, I find it just a bit differently. Ultimately, I'm not necessarily sure that changes what the results of the study are. And then I think that the conclusion of the study is very valid, that probably the bigger impact in the study is that patients are educated on the front end to understand what is really going on with their face and their nose. And if you get a good result to meet the expectations that the patient has, they're going to be happy. It doesn't matter whether they're reasonably symmetric or asymmetric, very crooked or not so crooked of a nose. And so I think that's kind of what I take away from this study as well. It's about pre-operative education, setting patient expectations, and then if you do good surgery, for the most part, most appropriately selected patients will do well.
Great. Well, thank you so much, Jamil. You brought up some excellent points. And I'm excited to hear what Babak has to say about some of the things you brought up. Before we do, though, we just want to turn it over to Dr. Steinbacher, who I can't think of a better person to speak on this topic, given your training and your areas of interest. So, Derek, please take it away. Thank you.
Great. Thanks again. Yeah, this was a great paper, and thanks for organizing this to ASJ and you, Mark. And those are excellent comments, Jamil. Thank you for that backdrop and this excellent paper, Babak. So a few things that I found interesting, the first was, which kind of leads to what Jamil was talking about, in this paper, it seems that the patients didn't necessarily recognize that they had asymmetry. It seems that in the methods that basically the different physicians or reviewers were assessing how much asymmetry there was. And in many of the images that you showed, most of the asymmetry really looked pretty well confined to the nose. So, I just wonder if you can comment on, is there a difference when the patient comes complaining of asymmetry? And, do you feel that most of the images that you were showing in those 61 patients, it was mostly nasal asymmetry, or was there really significant facial asymmetry as well? Maybe Babak can comment on that.
I think you're still muted, Babak.
Yes, really, when we review the face of all patients, you can find some asymmetry for all of them. But we need to categorize it into significant asymmetry, because no one's the face are completely symmetric. But according to our criteria, we divide almost half of them symmetric, and about the half of them are asymmetric. So we compared it together. I can give you the exact number if you want, but when we review the face, you can find asymmetry for all of them.
Great. Yeah. So, and I agree. You know, I feel like probably the majority don't really recognize asymmetry that they have in their face. And so that's something that we like to point out. And one reason I like 3D imaging is because we, before doing any types of simulations, you know, we really just look at their pre-existing face using 3D imaging. And that's a way that you can really point out a lot of that asymmetry to the patients themselves. And when there is asymmetry, I think it also brings up another challenge for us as surgeons in trying to figure out the midpoint of how we're going to centralize the nose to the face. You know, I usually do similar things to all the, you know, previous speakers, where drawing horizontal lines, but looking at natural head position from sort of a coronal plane. But I like to look at glabella, the philtrum, the central incisors, and the chin point. But in some patients, these structures might be off. And, you know, I've got a few examples that I can show of situations like that, which I think can make it challenging. So trying to figure out what is that anthropometric structure or landmark that we're trying to centralize on. And I know there's been several papers about that as well. But, you know, for the most part, glabella, but a lot of patients can have the philtrum that's deviated or a chin point that's deviated. And so we need to make sure that, you know, we're centralizing the nose based on some structure and that we point that out to patients in advance. Am I able to share a screen really quick?
That'd be great if you don't mind. You can just share your screen.
You should now be a co-host, so you should have the ability to do that now.
Great. Well, you know, the other thing I wanted to point out is that I think it's incumbent upon us too, if we do recognize asymmetry, and some of this is secondary to, you know, the bony structures or things that we think we want to treat, to ensure that we communicate this to patients. You know, sometimes it's similar or it's akin to when we see rhinoplasty patients or secondary rhinoplasty patients that have seen a general ENT for breathing issues, and they've already removed part of the septum, or they've done turbinates, and, you know, all of our building materials and building blocks are missing, and it makes it much more difficult for us to then go back and do a rhinoplasty without the septum. And it would have been great to do it all at once. I think similarly, when you think of sequencing, you know, if we're doing any osteotomies of the facial bones, that's ideally done first before doing something to the nose. So at least bringing it to the patient's attention and making sure, you know, they know that that could be something possible, or bringing up other treatment options such as fat grafting or, you know, implants to the cheeks or genioplasty, et cetera. But this patient, if you look at this, I just wanted to bring her up. This blue line is sort of the central portion of the face that's coming down through glabella, and it is lined up with the philtrum, but you can see that the nose is off axis, deviated more to the right. But then if you look at the chin too, she has right-sided condylar hyperplasia, so it's pushing her whole mandible to the opposite side. So she almost has a C-shaped facial deformity. And I think trying to set how to straighten that nose, you know, we have to think of the landmarks and parameters by which we do that. So for her, first, we wanted to set the facial skeleton as symmetric as possible, and then use that as the base to straighten her nose. So going from that to a little bit straighter and more symmetric. And then this is just, you know, rhinoplasty only, no real facial or jaw deformities or facial skeletal deformities, but she's a dermatology PA and has given herself injectables to her lip. But you can see this is the mid plane of the face on this coronal view, but her nasal structure is off axis, deviated to the right. And you can see that that's deviated that way as well. And because of her asymmetric injectables probably to her lip, she has a much longer philtrum and lip length on the left than the right. So if we're trying to straighten the nose based on the philtrum, that's sort of where her tip lies currently. So here, post-operatively, she's much straighter, but you can see the nasal tip is not really lined up with the philtrum, but I think it is lined up with the face. So it kind of belies or attributes that same idea that Babak was talking about, that if you straighten the nose, a lot of the other facial asymmetries will go away. Here on lateral view. And then on that submental view, you can see that the tip is much more over to the right, and it's lined up with her philtrum, but it really isn't lined up with the face, whereas post-operatively it's here. So just a few comments based on that. So I totally agree that it's incumbent upon us to point out facial asymmetry. I think the patients that come in already complaining of facial asymmetry are some of the more challenging to treat and deal with. We should always look at their underlying skeleton and offer different treatment options for these patients as well, including grafting, implants, or genioplasty to help augment or symmetrize the face.
Well, thank you so much, Derek, and excellent results as usual. I thought we'd kick off our discussion by, Babak, if you don't mind responding to the point that Jamil brought up in his discussion about dividing your photographs and your patients up in thirds rather than, in halves.
Yes. Really, as I explained to you, it's not the only way that we evaluate the patients. You saw that we have different method of evaluation for the asymmetry, and for the dividing of the face into three parts, we want to compare the visual assessment of the patient, the observer, to the anthropometric measures. So dividing of the face into three parts, it's not the only way we evaluate the asymmetry. So as I mentioned, at first we want to evaluate the visual assessment of an observer to comparing to anthropometric measures. So dividing the face into three parts is the first part of our study, not the method of evaluation of asymmetry. If we want to use some, for example, landmark like the glabella or the other, for example, a method of dividing, we cannot ask the observer the exact visual assessment. Really, I don't want to defend this method of evaluation. Definitely, Dr. Ahmed review is very precious for us, but we want to do more precisely evaluation comparing to a previous study. So we talked with my colleagues, Dr. Dastar, Dr. Kianfar, that's this was the research project with me. They told us that we want to do a better method of evaluation comparing to previous articles. So because of that, we divide the face into three parts, as we mentioned in my slides. And after that, we compare it to anthropometric measures. And the method of evaluation of asymmetry and evaluating of results, it was according to those landmarks that I told you.
Thank you. I thought, as far as crooked noses, I'd love to hear from our three speakers about whether, how you approach someone with a crooked nose, if you have a certain algorithm in your mind about when you do this, that, or the other. And I know, Babak, you touched on this a little bit in your article, but if the three of you don't mind, just briefly summarize how you actually approach fixing crooked noses.
Do you mean the method? I explained the method of surgery?
So you did explain it very well in your article. Maybe we move on to Derek and Jamil to see how they approach the crooked nose, and if you have anything to add, by all means.
Thank you. Yes.
Yeah, so I'm happy to interject. First, you want to see where the deviation is, how much of it is the proximal third, and is it the nasal bones and the bony aspect of the osteocartilaginous skeleton, or is it, you know, a lot of dorsal septum that's very deviated? Is there asymmetries related to the upper lateral cartilages, or, you know, the lower third of the nose? So first, I think diagnosing what the issue is, what the problem is, then looking at that in confines of the face, of course. If there's significant bony deviation, then some amount of, you know, straightening the bony vault, if just osteotomy is alone enough. It is sometimes, but sometimes you almost need sort of a monoblock segment. The septum itself, I think, is probably the most common cause of deviation, in ensuring that that posterior septal angle, anterior nasal spine is nice and stable and that straightened. Certainly in the most extreme cases, doing extracorporeal septoplasty may be needed, but at least straightening that posterior septal angle, anterior nasal spine, and then thinking about asymmetric spreader grafts or spreader flaps, trimming the upper lateral cartilages appropriately, and then finishing usually with the lower third in tripod.
Thank you.
Yeah, I mean, I just do what Derek says. No, but you know, I think in principle, many of us who do open rhinoplasty follow that same type of thing beyond the facial asymmetries. You know, straightening the septum, both the posterior, correcting the airway, and also the anterior septum, any caudal septal deviation. And then with the osteotomies to correct bony vault asymmetries, followed by the middle third, which can be any combination of, you know, upper lateral tension spanning, but it's usually some variation of auto spreader flaps, unilateral or bilateral spreader grafts, and then some of these septal rotation or clocking sutures to finish it, to get a bit more control on the dorsum. And then going to the lower third with addressing the tripod, making sure there's no asymmetries between the right and left lower lateral cartilages. If there are, sometimes it requires certain other maneuvers like transection overlap to shorten one side, or release and lateral curl strut to lengthen one side. And then going to the alar basis to look at nostril asymmetries, flare, nostril size. So I think the things I would point out, though, you know, kind of more anecdotally. Number one, in my practice, I think probably the highest risk for me having to do a revision on my own patient is the crooked nose patient. Because most of my crooked noses are highly asymmetric, highly deviated. They also have a big dorsum, asymmetric, large, malpositioned tip, and a bad airway. So they're like the full deal. There's so many moving parts. And within that context, I think there's just a lot of memory, and it's not only cartilaginous memory where you can get a bit of relapse of the cartilage, but even the soft tissue is different. When you look at these patients who have the classic deviated nose, it's almost like one side of the face and the nose overgrows, and the other side is hypoplastic, so the nose is growing away from it. And when you have that, you may be able to affect a lot of control, you can affect a lot of change to the cartilaginous frame and the bony frame. But I think the missing frontier is we don't have a good way to take out a lot of skin in soft tissue asymmetries, right? And oftentimes that skin does have memory when it's been held out for so long. And I think that also can contribute to trying to pull the cartilage back into its original shape. So for me, it's one of those things when I'm counseling those patients. Those are the patients that I'm speaking a little bit more to let them understand the complexity, so that they understand why, if they need some small revision, if things aren't exactly like we had hoped for, that's why it is, because they have a very complex problem. And then the second thing that I find very difficult in crooked noses and deviated noses are high deviations. So where the cranial bony septum is shifted anteriorly. So right where the L strut typically attaches, if you have a big deviation of that cranial bony septum, you know, that's a high price piece of real estate to just go in and try to do high osteotomies or just disinsert the L strut. And oftentimes you can do a lot to it, but you can never get them quite straight unless you do something very radical. But doing something radical comes with a significant amount of risk, because you can totally lose all the support in the rhinoplasty, and then that becomes a bigger problem.
Thank you so much, Jamil. I had one more, just a reminder, by the way, to our
Excuse
audience.
me, Mark. Can I add a comment for the method of surgery?
Please, please, please.
Yes. when I compare what I do today with the before, I am now I am more aggressive for the septum. In the past, I used some type of conservative septoplasty in the past, but for deviated nose, I use more usually from the, as I told you, modified extracorporeal septoplasty. When I do, when I am now more aggressive for the septum and I try to reconstruct the septal, sometimes use the rib graft for the reconstruction of septum, my results is, I think, better than before. Also, I use the bony graft, especially bony batting graft for reconstruction, and be sure for the future outcome. Because what we think about that the cartilage memory or something like that, that we have some recurrence in deviation, sometimes it's related to that we need something more stable or completely reconstruct a structure. When we compare that, yes, possibly in the end of my surgery, everything is good, but when we review our results after 1 or 2 years, we can see that our result is not stable. If I want to point something in my method of surgery, is that think about fixing of any deviation with something is stable, or reconstruct a structure instead of that reshape it or something like that. Thank you so much.
Thank you. So a reminder to everyone listening, if you have questions, please enter them in the chat box or turn on your video camera and feel free to either ask a question or make a comment. So for our 3 experts, I actually have a very specific question that I'd love to hear your thoughts on, if you don't mind. Derek, if you don't mind sharing your screen again and showing your first pre-op patient, there's a question that I have that I don't think we hear talked about very often. And I'm curious how any of you would deal with it. It's basically regarding alar rim asymmetry, a situation where you have one side higher than the other. And the question is whether you choose to bring one side down, bring the other side up, or do you augment the maxilla? What's the best way to treat this? And when we get to that picture, I'll show you what I mean. Yeah, right here. So you can see her left alar rim's higher than her right. And I just find that patients come in frequently complaining about that, and we just don't hear it talked about very much. If any of the 3 of you have any thoughts. Is my question clear?
Yeah, asymmetric alar retraction, basically on frontal view. And she's interesting in that she had actually a prior rhinoplasty in Lebanon. So this is post rhinoplasty, but then she ended up getting orthognathic and then a revision rhinoplasty afterwards. But, you know, I think there's 2 ways to look at it. One is just lateral to the soft triangle. And first too is looking at the shadow, some of the shadow overlay here where, you know, it's basically cephalic malposition of the lateral cruce that's creating some of that, and having a shadow or a break at the ala here. But what I see to an extent is just lateral to the soft triangle. The ala is a little bit more retracted on the left than the right, but also if you look down at the facial base at the alar facial crease, this takeoff is a little bit more superior than the other side, which we see a lot.
That's exactly what I'm asking about, exactly. So if someone doesn't like that one side is higher than the other, you know, to correct that, and I think back to my training, we did a cleft nose, and I was with a very experienced craniofacial surgeon, and she basically moved her left side down in this case and used multiple permanent sutures, only for it to recur 3 months later. So it's not an easy problem to address. I just wonder what you would do for this.
Yeah, so in cleft patients, it's because of lack of bony support. For her, she actually had a cant this way. You know, I'm not showing any of the occlusal or maxillary pictures, but she had a cant down to the right, which sort of accounts for that too. And once we stabilized or straightened on the coronal view, the maxilla, that helped with it. But if there's nothing like that, and you know, you can obviously see some of this with a perfectly symmetric maxilla, then, you know, I think it's focusing first on the tripod and, you know, whichever techniques you're using. And I've been using more articulated alar rim grafts and place the pockets in a way that allow us to push this down. So on this side, I would certainly make the pocket more caudally, and on this side, I would keep it sort of at the same position or a little more cranially or cephalically. If there's a alar base excision or resection required, you can plan that asymmetrically too and extend onto the facial skin a bit, whether or not you need to come into the sill or not, but that's really quite powerful in correcting this. One thing we do a lot on cleft patients, the cleft side, the ala is usually much shorter and almost a skin deficit. And we're working on a paper for this now where we take a composite graft from this side, basically take, do a weir or alar base excision on this side, but instead of throwing that tissue away, opening this up where it needs to go and interposing that skin or composite graft. I call it composite just because there's still some muscle with it on this side and can really help with symmetry. But those are a few ways that we try to think about it. Skeletal underpinnings, the tripod, alar rim grafts, and then modifying the skin at the alar facial crease.
Thank you. Any other comments from anyone?
Yeah, I think also it's important to recognize what's within the nose and what's not within the nose. So, when you're doing rhinoplasty in isolation, you can affect change within the nose, but where the nose meets the upper lip or the cheek, that's kind of an area. It's kind of the like with alar cinch procedures, why they don't really work well, because the problem isn't the width of the nose, it's the problem of the width of where the cheek ends, right, on both sides. And so in order to control that flare on patients, you try to do a cinch, but that's never going to hold up against the facial mimetic muscles over time. That's why those procedures are notorious for a high amount of failure. But if you look at what's within the nose on this patient, you'll never be able to perfectly correct it, because the issue is that where it meets the lip and the cheek is at different heights. However, one more straightforward way that you can affect some changes on the high side of the alar base, if you dissect your pocket all the way back to the cheek, right, to the piriform, and put a longer graft, it will give a little bit more fullness and push that down a little bit. And a lot of this is not necessarily about completely correcting the problem, but oftentimes it's about camouflaging it, getting a bit better of a balance, as opposed to making where it attaches to the cheek or the lip the exact same. So there are some things you can do that are low consequence, low investment, but can make those subtle changes to give the patient's recognition of the problem, or make the patient not perceive the problem as much.
Thank you so much. Any other comments?
I completely agree with colleagues, but for such kind of cases, if you do a CT scan with the 3D reconstruction, you can see the asymmetry of midface and the effect of those asymmetry on the nose. Sometimes we try to fix the nose, but the basement of the nose is not symmetric. So you cannot fix only the nose when you have some problem for the skeleton. I think the concept of the cleft nose sometimes, not exactly for this case, very useful for us. Sometimes we need to do some type of foundation graft for the base. When we balance the base of the nose, after that, if we do some type of articulated rim graft, special techniques for the alar base resection is need for those cases, can fix such kind of things correctly. But also I agree with Dr. Ahmad, because sometimes we do all things, but because of the different insertion of the muscles from two sides of the face, you cannot completely fix it. So thinking about the muscles, the insertion of muscle and the effect of muscles, because we don't only do something, it's a dynamic, the face. Sometimes it's better to tell the patients that yes, we can have a little better than before, but we cannot completely fix such kind of problem, I think. Those that our colleagues told us that that's the new technique for the fixing why usage of the composite graph is very interesting to me. Thank you for sharing for us. Thank you.
Thank you. I'd love to turn it over to Dr. Sarhadi at this point for poll questions and any other questions.
Good evening, everyone. Thank you all for joining us. We're welcoming people from North America, South America, and then Asian continents today. And it looks like within our audience today, about 75% of our audience does rhinoplasty as part of their practice about 25% of the time. 20% of us do it around 25 to 50% of the time. And only one of us does it about 75% of the time. We asked our audience about their experience with a crooked nose patient and underlying asymmetries. And in our audience's experience, patients with a crooked nose, 75% or 70% of them tend to think that these patients also have more facial asymmetry as well. 30% of us in our experience does not have that experience. And then also the effect of facial asymmetry on patient satisfaction, which seemed to be one of the biggest points for this article. 10% of us think that has really no effect. 10% of our audience believes that patients with underlying facial asymmetry tend to be relatively unhappy, regardless of rhinoplasty results. And a third of us tend to believe the opposite, that these patients tend to be happy with their rhinoplasty results despite underlying asymmetry. And then finally, half of us think that it just depends on the relative asymmetries of the nose and the face. And then finally, looking at the chat box, our first author here, Dr. Dastar, I believe he's still on the call. He had some comments to make. I don't know if he's still here. I would love to introduce him. But he made some comments about the method of facial symmetry assessment for this study. And part of the reason why they, well, I guess Dr. Saidi can probably comment on this or already has, but part of the reason is because if someone has asymmetry of the lower face and they're characterized as facially asymmetric, then that might throw things off a little bit. So that's basically what we have here. Again, I don't know if Dr. Dastar is available to make a comment.
Do any of our speakers have any further comments?
Oh, here he is. Ah, okay. Yeah, that's what we have.
Okay. Do any of you three have any questions for each other? Any final comments? And if not, that we appreciate your time for sure. All right, well, we are over time already. I just want to thank Dr. Saidi, Dr. Ahmad, and Dr. Steinbacher for spending their time with us tonight. I really thought it was an absolutely great discussion. I wish we had a lot more time to continue it. So thank you to Abby Pugh and Phaedra Kress for all of their work in making tonight a success. I encourage everyone to tune in next month for the ASJ Next Generation Editors Journal Club. It's hosted by Dr. Ryan Austin, and we'll be back the following month in August for the YAPS sponsored journal club. Thank you again, everyone, and I hope you all have a wonderful night.
Thanks, everyone.